Thank you very much, Kiran, and I appreciate DWRF and ACAP. Catherine, Mala, and Kiran has very nicely put together this meeting, and I actually had great learning hearing everyone. So I will give my perspective as a clinician, as you can see from my first slide, about health empowerment of the elderly in the Pakistan and how we have managed during COVID. My first slide is from the Holy Prophet, peace be upon him. One who pleases his parents has verily pleased Allah, and one who has angered his parents has verily angered Allah. And starting by this slide means that I think we all need to understand the social religious background based on the geographical location and the society we are dealing with. And it was great to hear everyone from their perspective. So as a clinician, when I see a patient in the clinic, what we usually do is the physical assessment of the patient, making sure what's going on in terms of their medical problem. But what I realized after coming back to Pakistan is I also need to look into the other factors, which were the psychological and the spiritual factor of especially elderly population. There are a lot of initiatives taken by the government in the past few years, but there was still a gap. And after listening to today's presenter, I actually learned many new things, and I think I would like to implement those in future. So what I like to do is not only assess a patient clinically or know what's going on from the pathological perspective, I also try to look into their psychodynamics at home as well. If there is any stress factor, is there something which is bothering them beside the disease, which is a pathological process and can be corrected with medication. Also, what I try to touch upon is the spiritual factor, because as a whole, as a human being, we need to address all these factors to make one complete human being addressing or interacting with the environment around them. So most important part is the issue of the aging population. What I try to talk to them about is understanding the concept of normal versus pathological aging. And what I try to communicate is not only to the patient, but also to their family, to make them understand, is it really pathological? If it's a behavioral issue which can be addressed with the medicine, or there is something which is affecting their psychological well-being at home. So addressing that factor, it could be just not having a stair to go one level up, or not having a proper other maneuvers to walk around or be independent. What I also try to communicate to them is about the neurological decline which comes with aging. Sometimes we become indifferent about what's going to happen with the age. If there's going to be a neurological decline in terms of calculation, monetary issues, just we talk about making phone calls, or there could be neuromuscular decline in terms of their physical capability to do certain chores. If they are not able to perform the routine stuff at home, how they can manage? Do they need to have some help? And how they can arrange that help at home? The other very important factor which I try to communicate to my elderly patient population is about invisible second patient, which is a very important concept for the society as a whole, and especially for the elderly population who are running into dementia and other neurological problems, because most of the time this invisible second patient is the spouse. And usually in our society, because it's a family-based system here, and most of the time it's the wife who is a couple of years younger than the patient, and she is actually the invisible second patient because she is probably suffering more because of the patient's condition. So what I try to communicate to the kids or the children in the family or the family members, that they also not only take care of the patient, but also of the spouse of the patient or the mother as well. The society attributes in Pakistan, we also try to communicate to the patients in the clinic about the capacity of decision making. It not only involves the simple decisions about what to wear, what to eat, but also about making bigger decisions which could be life-changing. Because of the combined family system in Pakistan, the elderly people are usually considered to be virtual head of the family. They may not be making the final decision, but they are actually considered to be part of most of decisions, which is good to keep them involved, and they also feel more involved with the family decisions. Also, there could be socially, they are, as I said, considered to be very much involved in the family matters, which is important. And also it gives them the autonomy and authority in the family as well. Religiously, as just I elaborated in my first slide, they are given very prime importance, but naturally there are other incidences, or I'm going to talk about few where the patients have to move out of the family, or the elderly population are not taken care of as much as they should. So they are neglected. In that case, there has to be some legal help. And as a matter of fact, the government of Pakistan has recently passed a law as well, where the kids or the children in the family cannot move the parents out of the house. And in case they do, they have to arrange a new house for them and to support them from the monetary perspective. And if they don't, then there are legal repercussions to that. There are naturally limitations to every society and every system. But what I try to do and what I have been trying to implement in my patient population is to make them understand the pathophysiology of the disease. Naturally, it takes time to sit with them in the clinic and to guide them about the pathological process. It could be dementia, it could be Parkinson's disease, it could be their other chronic medical problem. Due to limited health resources, this is somewhat lacking, that the doctors give less time in the clinic. But I think this is one way to bring a change in their life, to communicate, to let them know how they can improve small things to make their life better. Especially when they have elderly at home and they have to go to job, because I know some cases where the kids have to quit their job, or they were doing job from home because they were not able to arrange someone to take care of the elderly at home. The other limitation is about lack of education. The literacy rate in Pakistan is 62%, but a good number of population of patients is one who can just write down their names or few sentences, and they are not educated to the point that they can understand the medical stuff. So it's hard for them to understand when you just say that they need a speech therapist or occupational therapist. You have to guide them about what does that mean. The other important part is about falls and fractures. Because of lack of education and poor nutritional status of population in general, because it's a developing country, I think that is another big limiting factor which affects their mobility and the well-being as a whole. The other part is the unhealthy lifestyle, which means that there are not enough open spaces, there is lack of interaction, there could be poor social support or poor monetary support, resulting in poor nutrition, and general well-being in general is affected. So what has been done recently, because there has been some initiatives by the government. So they did a study and they noticed that 72.4% of the geriatric population seek medical advice at the private hospital, which is naturally expensive and it comes at a high cost. So the government recently has taken the initiative to start the health card. So the head of the family actually has that sum in their card where they can use for their health care. They can go to any private or government hospital of their liking, And we hope with that there's going to be change in the healthcare, especially for the elderly, because they will feel more in control. The other numbers in this slide are basically international numbers taken from US, because there were not enough studies in Pakistan. But I think these numbers can be reciprocated in some way in Pakistan as well, because what has been noticed in those studies was the caregivers are 65% females, which I have just mentioned is kind of similar scenario, because those are usually a couple of years younger than the male spouse. And they are the main caregiver or taking the burden of the elderly patient who is actually sick. 21% are 65-year-old or above. 40% of the spouses have college degree, which I feel in Pakistan this is going to be a much smaller number, because the literacy rate is not as much as what we see in developed countries. And 71% of these patients were married or in the long-term relationship, which I think is a good part of the combined family system or the married life, because that helps the spouse to understand the need and to communicate better, because they have been together for a longer period of time. So in terms of empowerment of the elderly, I think what has been done, or what I have been trying in my practice, is communication, because I think that is the key, whether it is the communication to the patient or to the spouse or to the rest of the family members. What I also try to communicate is about understanding the psychosocial dynamics, or understanding the stress factors of the family, trying to communicate and give them some ideas to improve it. And I think also the family need to understand the limitations, because if they will not understand the limitations, they will not be able to address it. So what I do is put the limitations in front of them after discussion with them, and make them understand how they can come around it. The other big part is in terms of the education. Naturally, I saw some slides in terms of the education of the elderly. There are evening schools which provide education for the elderly as well. And as I said, the Prime Minister recently took initiative about the nursing homes are lacking. So they have started something called shelters. Those are open to everyone, females and males, elderly as well. And in a recent study where there were more than 5,000 people, elderly population were actually observed or studied, and they noticed that most of the people opted to move out of the house or from the family because of the lack of social, psychological, and monetary support. So I think what needs to be done is already in the pipeline. It's happening, but things are slow, and I hope things will be improving with the passage of time. But due to COVID, as everything is slowed down internationally, it's kind of the similar scenario in Pakistan as well. I also try to communicate about the social interaction of these patients. These panaga or shelter homes are also one way to do social interaction. In terms of the COVID measures, those are not very strongly followed, as you can see from the photograph, but I think that is one way that people interact. Also, the telephonic communication is other, which is basically taken by people who are able to use phones. As a physician, I think I have a role to play in the society and community, especially during this hard time of COVID. And actually, we started some other initiatives in terms of how to communicate this idea to other people. This is my clinic data. I have seen in the past 3 years, I came back to Pakistan, more than 3,000 patients, and more than 60-year-old patients were close to 550, which is about 1/6 of the patients I have seen. Almost 80 patients had dementia, 60 had Parkinson's disease, and dementia can be associated with that. The population of my hometown is close to 2 million, and I feel based on 10 other neurophysicians working in the town, there is a ratio of 1 elderly patient with dementia in a population of 1 to 1,000. We have started the YouTube channel where we did lectures, because I think media has a great role to play in terms of social isolation and education of the elderly. In the present time, many people use cell phone. I feel almost everybody carries a cell phone with them, and most of the cell phones have the capability to use YouTube. And we did a couple of lectures, and there was a great response from the family and also from the patient in terms of their learning how to manage things, how they can do some exercises at home to prevent falls. But at governmental level, there are some activities, but I think there is more need to be done at personal level and as a group as well. I really appreciate, again, at the end, to DWRF and ACAP. My email address is there if there are any questions. And it was a great discussion so far. Thank you so much, everyone.